Hi, good morning, afternoon, wherever you are. I'm Dvora Entin. I'm a licensed clinical social worker and a perinatal mental health specialist, and I am the clinical consultant with Yesh, Tikva, a Jewish organization that focuses on infertility. And I'm so thankful that Dr. Diana Chavkin has been willing to meet with us and talk about her own life experience with infertility and as a reproductive endocrinologist. And we'll just have a conversation, talk it through a little bit, and we'll learn a little bit about your process and what it's like for you as a physician as well. So Dr. Chavkin, could you introduce yourself to us? Let us know who you are.
Sure. Well, thank you first of all for inviting me to speak with you here today. My name is Diana Chavkin. I'm a fertility physician here in West Los Angeles at HRC Fertility. I've been practicing here for about 3 years, and prior to that, I practiced for many years in New York City, which is where I'm from. But I'm very happy to be here in Los Angeles, and I'm loving my practice here, loving my patients. It's growing and just been a wonderful experience. And yes, I was also a fertility patient. Actually, both of my children are from IVF, and I've done multiple IVF cycles. Didn't just take me 2 cycles to get my 2 babies. So I've been down the path that many of my patients go through, and I'm very vocal about my experience. I hope that my experience can help to help people, but help my patients. And so I'm very open, and so I really appreciate you inviting me here to speak with you today about my experience. And I really I love Yesh Tikva. I love what you guys are doing. So I'm very happy to support it.
Great. So I was thinking about, when you talk about being a patient and being a physician, and I think about how interesting or unique or complex it could be to sit on the other side of the table, right? To sit on the other side of the exam. And I'm wondering first of all, if you could tell us a little bit about your fertility story and help us understand like how you got to where you are today. And then maybe we could address what it is like, how it's different for you as a physician being a patient at the same time.
Sure, absolutely. So there's a lot there. So let me sort of tell you my story. So in kind of my mid-30s, I was at the University of Pennsylvania, and we were doing a lot of egg freezing. And at that time, I was considering freezing my eggs. I knew I wanted to have children. I wasn't exactly ready at that moment. At that time, it was still considered experimental. We were doing it a lot because we had a lot of oncofertility, a lot of cancer patients, and we were doing it. And at the time, I considered freezing my eggs, but I said, okay, I'm not going to. It's experimental. I'm not exactly sure. And so that was something that kind of stuck with me because it was a decision I kind of made. And I look back at it, especially when I fast forward a few years, was going through my own fertility treatment, wishing that I had frozen my eggs. So that's something that definitely informs a lot of my counseling, just from my own experience, having kind of missed that opportunity to freeze my eggs, and then having gone through fertility as a fertility patient, not having any sort of security blanket, not having any of those eggs frozen. It was kind of an interesting experience for me. In any case, like I said, fast forward a few years, I then found myself in New York with my husband, and at the time we were trying to have children. I did actually a few Clomid cycles, just because I decided that was going to be my first line treatment. And other than having, being my late 30s and having, potential age working against me, I didn't really have a clear diagnosis. And so we started with a Clomid cycle. And, it was interesting to me. A lot of times we think about Clomid as kind of, this very benign medication. It's an oral medication. A lot of OBGYNs will just give it out. Oh, just try this, almost like a prenatal vitamin. Oh, you're trying to get pregnant, take Clomid. I have to say, and I know just from the textbooks, like I've always known for years before that Clomid has side effects. But I had some serious side effects from the Clomid. I don't think I ever felt worse out of all the medications I've ever taken. And like I said, I've been through multiple IVF cycles since then. But the Clomid, I really just didn't love how it felt. And so it's a conversation I have with my patients. I mean, I definitely still use Clomid. It's definitely part of my toolbox, but I urge people to realize that, an oral medication, even though it's an oral medication, can affect all different parts of your body. You know, you're taking something systemically. And so that was my experience with Clomid. So
I just want to ask you one quick question about the Clomid. You're saying that it affected you. Were your side effects physical, or did you really have a lot of that emotional lability? Yeah. I mean, it's one of the things we hear a lot about from Clomid is that real emotional and mood dysregulation that can make you into the raging lunatic, right? Clomid rage. Yeah.
Absolutely. And yeah, definitely. I mean, it really, like, it kind of tricks your brain into thinking you're in menopause, right? Your whole body, you have hot flashes, you know, yes, mood fluctuations, sleep disturbance, all that stuff. I mean, it's for a short period of time, and it really is a good, effective drug in a lot of settings. So I wouldn't say I'm totally against it. I guess I'm just saying that in one sense, we think it's like this benign medication, but in the end, everything has its side effects. And for me particularly, I did have some interesting side effects on the Clomid, including the mental, emotional, and also some physical stuff. In any case, but Clomid did not work for me, and so I proceeded pretty quickly with an IVF cycle. At this time, I was in my late 30s, around 39. Did an IVF cycle. I actually just knocked on my colleague's door, my practice in New York, and said, okay, I'm ready to do an IVF cycle. And she said, okay, let's just start. And it was like after hours, and I was in the right time of my cycle, and we just started. I had like no real workup. I kind of wasn't really, I don't know. I guess doctors are the worst patients, right? So in the middle of my medication, in the middle of my stimulation regimen, we did a water ultrasound. So the way that you're really supposed to do it by the book is you're supposed to do a water ultrasound to evaluate your uterine cavity before you begin the injections to stimulate your ovary. I did it out of order. I did the water ultrasound in the middle of my cycle, and lo and behold, we found a polyp, a uterine polyp. Not a huge deal, but it's the kind of thing, and at least a few years ago especially, we used to think that a fresh transfer was better. The data has since come out, and a lot of practices have their own specific data to corroborate this. Now we think that actually frozen transfers are better. I think we've just gotten better at the frozen technique, and so therefore outcomes are actually shown to be better. But back then, it seemed that fresh transfers were better. So when I was in the middle of my cycle planning to do a fresh transfer, lo and behold, I have a polyp on my uterus. I was very distraught. I said, okay, well, now we have to freeze my embryo. So I went through a cycle, froze embryos, then had to do a procedure, a surgery, a hysteroscopy, where I had my polyp removed. At the time, this was so disheartening, right? It was like, I mean, one of the things, you know, as a fertility patient, you quickly realize is that life is a roller coaster. It's like it's up, down, up, down, up, down, and you're constantly rolling with punches. So this was one of the things that kind of set me back. Had to freeze embryos. Then I subsequently, after I had my surgery, then I did another IVF cycle, and then in that IVF cycle, I did PGS, and I had one chromosomally normal embryo and did a fresh transfer, got pregnant, and delivered at age 40, and that was my first child, who's actually about to turn 4 years old this month. Essentially in that time period, I then subsequently moved to Los Angeles. I was breastfeeding for a year, and this is kind of very, very personal, but I'm happy to share it just because I feel like it really, I don't know, these hard stories can give strength to people, so that's why I offer it. So I'm very open about it. But I essentially conceived naturally. Was actually very happy about it at the time, but I actually soon found out that it was chromosomally abnormal. And therefore had to have a termination. And that just really, I was like, okay, I was a fertility patient, I got pregnant, but then all of a sudden I'm so happy I got pregnant naturally. And then, that was probably one of the hardest things I ever had to deal with. After that, I was just totally committed to getting pregnant as soon as possible. I subsequently went through, I don't even remember how many, but went through multiple IVF cycles here at HRC with my colleagues who were amazing, so supportive, so wonderful. Got really good outcomes, but because of my age, it was a bit harder to get a chromosomally normal embryo. In terms of what the lab and what my colleagues were able to do for me, they did a great job. It just happened to be that my body was not cooperating in terms of creating a chromosomally normal embryo. And so I then decided to go back to my frozen embryos from way back from a few years ago that I had to freeze in that first cycle. So remember, it was that first cycle I had to freeze embryos, and I was totally distraught at the time. I used one of those frozen embryos. Fast forward, my second IVF baby was born about a year ago. And that was from the frozen embryo from my first cycle. And so I give you all of those details just to kind of, one of the main reasons is really, you know, some people say everything happens for a reason. I kind of will say, just my personal feeling, I don't feel like everything happens for a reason, just because there are just some really bad things that are very clear are really bad and they happen. And so I don't believe everything happens for a reason, but I do think that at the time when we're going through things, we don't know necessarily how things are going to play out, and we don't always know that something is necessarily bad, right? We can sometimes label something as bad, but in the end, we don't know how that's going to cause repercussions for subsequent things that actually may be the best thing that ever happened to us. So at the time I did my first IVF cycle, I was so distraught. I had this polyp. I felt so irresponsible. How could I do this? Now I have to freeze my embryos. I can't go through a cycle. In the end, I have a second child because of that uterine polyp, right? If I had never frozen those embryos, I would not have had the chance, first of all, to have my first child in my fresh transfer, and then to have my second child. So it's a message, I think, in life. It's a good lesson, but it's also, especially as fertility patients, I mean, we just are on this roller coaster of ups and downs all the time. And I think that sort of the ability to kind of just step back and say, okay, this might be a setback, but in the end, you know, we don't know what the repercussions of that might be. So it's just important we just kind of pull ourselves up, listen to our doctors, when we should continue, when we should stop, right? Be in connection with a mental health professional that can help us see clearly. But in the end, we don't always know, you know, what necessarily is a real setback and what is just kind of something where you just have to roll with the punches and see what happens.
Would you say that that was probably like the number one lesson you learned from being a patient? And how does that like inform your practice today?
Yeah, I'd say, I mean, that's a big one, right? That's a big one, because that whole like disappointment was very, very real. And lasted with me for a long period of time. And it wasn't until years later where I was able to actually see, oh my God, thank God that happened, right?
Right.
And so, yeah, that was the biggest lesson. And it definitely is something that informs my discussions with my patients all the time. I mean, I think, you know, I see obviously happy patients all the time, but I also see disappointed patients all the time. And I think, and I do share that story with people. And I think that experience that I had definitely puts that at the forefront of my mind as something that I, you know, try to reassure my patients about.
What do you think? I think about what it must have been like to be a patient and a physician at the same time, literally even in the same practice, you know, what it means to walk out from a failed cycle into somebody else's successful cycle, or somebody else's failed cycle, and really how deeply that must have resonated with you emotionally.
And so, there's so many things to say about that. Just, I mean, right. And also like being a pregnant, like obviously pregnant patient, and I'm also very vocal about like my experience, and to say, yes, you know, this is an IVF pregnancy and here I am pregnant and I'm here to talk to you about your failed cycle, right? Like how does that all play in? I mean, I think what I've learned, it's all about being open, and I am very honest and open about it in the hopes that I give people strength. But of course, it can be hurtful. It's hurtful just as a fertility patient. You see somebody walking down the street with a baby carriage, it's hurtful. So of course, I mean, I'm sure that it is, but I hope that like in the grand scheme of things, my experience hopefully can potentially give strength to people. So, but to your question about, you know, what it is as a doctor who's, you know, a fertility doctor who's going through it. I mean, I will say the hardest part was at the beginning of my fertility journey when I didn't have any children. And I was coming to the grips with the fact that I may not ever have children, right? I had a lot of setbacks at the beginning, the Clomid cycle, the not great experience with it, the realization I had to proceed with IVF, and then my IVF cycle had to be canceled, and then I had to have surgery. There were a few months there, if not, I mean, way more than a few months. There was a long period of time where I was taking care of patients, and I had to, you know, not just show empathy, but have empathy for people who were coming in, let's say for their, you know, second or third baby. And here I was trying to have my first.
Right.
But in the end, it's not about me. And then it was a good, I don't know, like muscle building of empathy, where I kind of like, you know, it's one thing to have empathy when someone is clearly, you know, doing worse than you, right? But if somebody's doing better than you and you're doing worse than them, how do you have empathy? And it really is about like separating yourself, right? Like I am there to support you and take care of you and give you the best care that I can, which also includes having emotional and psychological empathy. And in order to do that, I have to separate myself from you. So I'm not saying it was easy, but it definitely was a muscle that I did build up at the time, that I believe I was able to like use that practice in
like in other situations.
My practice now, and allows me that empathy because of what I built back then.
What do you?
Oh, sorry.
No, go ahead.
No, but I had to separate myself from what my patients were going through. Like I couldn't say, oh my God, but you're doing so much better than me. You know, like I couldn't, obviously I couldn't say that, but I also couldn't even think that.
Where did you get your support from? Like what was your support? Who was your support structure? And like, who are the people that you turned to when you were going through it?
It's a really good question. When I could do exercise, I will tell you exercise was huge for me. So running for me was very meditative, which is also why it's hard sometimes when you're going through fertility treatment, because you actually can't turn to that. And I see have a lot of my patients who depend on that. And I could definitely relate to that, because for me, running was very meditative, exercise is very meditative. So not being able to do that was hard. But when I was able to do it, I did turn to that for help. And also yoga and meditation. To be honest with you, I think that was the biggest part for me. And colleagues. I think that my journey probably would have been a little bit easier if I actually did turn to a mental health professional. I did not. And I think that's probably why I, in my practice now, really emphasize it probably for every patient who walks through the door. I think that I would have had a better, easier experience had I consulted regularly with a mental health professional.
Right. 3 cheers for the mental health world.
But I didn't. Like I said, doctors were the worst patients. But I say I got my strength from exercise and yoga meditation when I could, and then colleagues.
I think about like as a physician and you being so deeply informed about the medical process and knowing all of the stages and steps and options. I think one of the things that probably is so confusing to people who are going through the fertility experience and that kind of stepping into that new language, was it easier or harder for you to know so much information? Because I think sometimes there is a certain level of trust that we just give to our physicians to say, just tell me what to do. But you were much more probably invested in that process from a knowledge base.
No, I was running my own cycles. Like I was deciding when I would be coming back in and getting my blood work done. And I was lucky in that the doctor who took care of me in New York and my colleagues who took care of me here at HRC really like respected that and had conversations with me at my level, obviously, and allowed me to make decisions. But they also sort of made very clear when they thought that maybe like I wasn't thinking so clearly and tried to step in and just be like, listen, if you were just a straightforward patient, this is what I would say to you. And sometimes I'd have to have that conversation with them. I'd say, listen, I feel like I'm sort of running us both in circles. Just make believe I'm a patient and
tell me what to do.
Tell me what to do. Exactly.
Right.
I think overall, to be honest with you, it probably was easier. I really do think that information and knowledge is key, which is why I spend a lot of time with my patients educating them. I think that the more educated you are in the process, you're able to make better decisions when you know what's going on.
Yes, definitely.
In the end, yes, like too much information or too much control, like being your own doctor isn't necessarily the best thing, but I don't think it's the information or the knowledge that's bad. It's just too much control over yourself.
It's interesting because I think that's one of the things that I hear and I see so much conflict among patients with this idea of like, well, I don't know if it's my place to ask that question or my place to suggest that I should want or ask why we're not having this procedure while we are having this procedure. And really, I think I think what's valuable as a community is really helping patients feel that empowerment to be able to say, can you help me explain to me why this or why not that? And I think a solid physician that is nice and confident will be able to more than happy answer those questions and give that collaborative kind of approach to medical care, which is so valuable when everything feels so completely out of control.
Absolutely. Yeah. I mean, well, there isn't one way to skin a cat, right? There isn't one absolute way, right? We don't have crystal balls. We can't say, well, if you do this, this is going to happen. And if you do this, oh, that's going to happen. So you shouldn't do that, right? It's kind of, we don't really know. We make our best you know, recommendation based on the information we have. But in the end, a lot of it is a discussion, right? A lot of it's a joint decision. There has to be some sort of like joint responsibility here. But in order for a patient to be a good participant in helping to make that decision, they have to be educated. Yes, and so definitely. I think it's our jobs as physicians to educate, number one, present all options, have discussions about all options, put them all out on the table, and then come out with as good of a, you know, game plan as possible based on all of that.
Right. So I'm mindful of the time and wrapping us up. I wanted to ask you two quick questions. One is I want kind of like your top 3 takeaways that you want to convey to the community that might be listening to this from what you've learned as being a patient and physician. And the second thing I want to just ask you, because you brought up is that concept of fertility preservation, you know, the idea of recognizing that as you said, you know, you said the embryos were not growing, the eggs were not growing the way that we wanted them to, and the embryos were not as healthy as we wanted them to with that second round because of age. And we know that age has a deep impact in genetic normal and abnormal development. So I'm just wondering, your 1 minute, your 1-line plug on fertility preservation. Age, what would you say, when are we starting to talk about this for women, and just kind of encouraging that thought process?
Yeah, so let me start with the fertility preservation part of things. So yeah, fertility preservation, I am a huge proponent. As I started with this whole thing, my first setback was, well, when I first started to think about these things, and I was speaking to my colleagues at Penn, you know, about fertility preservation. A lot of them were encouraging, and in the end, I made the decision not to. And fast forward a few years, when I was going through fertility treatment, I absolutely was kicking myself. Why didn't I do fertility preservation? You know, I could have had my eggs frozen. I would have had a much easier time. I mean, in the end, things worked out for me, you know, the way that I'm happy they did. But it was a very scary time to going through treatment, not having had that security blanket. You know, listen, freezing eggs doesn't mean that you're freezing your eggs, right? It means that you're freezing a certain number of eggs at a particular time that will allow you to increase the chance that you can have a child in the future, right? So if you freeze your eggs in your mid-30s, your chance of pregnancy, your chance of chromosomal abnormalities, your chance of miscarriage are locked in at the age at which you froze your eggs. So if you use your eggs at the age of 40, but you froze them at age 33, your chances of pregnancy from all of that stuff is dependent on the age at which you froze them at age 33, which is a much better chance than the age of 40. So if someone were to potentially need fertility treatment down the road, if they have their eggs frozen, they're essentially able to be their own egg donor. As opposed to needing, you know, a donor. And I often will treat patients who say, they come to see me, they have serious fertility issues. Using their own eggs is not an option because of age, because of their particular fertility ovarian reserve. And so we have to sometimes resort to using an egg donor, which is a wonderful, beautiful option. And many patients are, you know, happy and have babies that way. But how nice would it be if they could be their own egg donor and obviously, you know, use their own genetic material to have their babies. So it gives people options. And, you know, I think the only concern with egg freezing is it costs money, obviously, and you may not use it. It's sort of like with any kind, I don't want to say insurance plan, because insurance means that like you'll get paid if something happens, right? So and egg freezing is not a guarantee that you're going to have a child one day, but it increases the chance that you will have a child one day.
Right.
And so I really firmly believe that any, you know, woman who's interested in having a child in the future, who's not ready right now, should consider freezing her eggs.
Is there an age? Is there an age in your mind?
So I think kind of like mid-30s, but really, I wouldn't say 35. I would say even like a little earlier, like 32, 33. You know, at the age of 35, that's when we start to see a real, and on the average, kind of an exponential decrease in fertility, and also an increased chance of chromosomal abnormalities. I mean, that increases as women age, right? Like in their late 20s, early 30s, mid 30s, like that goes. That issue increases all throughout a woman's life, but particularly in a woman's mid-30s on average, that's when you start to see a real flip of the switch in terms of issues. And so if you can get women in before that happens, I think that you're in a better place. So I would say, like, you know, early to mid-30s should be when people think about it. But it shouldn't be a situation where if somebody's in their late 30s and is interested in having a child in the future but is not ready now, it's not like that's too late. right? So we know that from a lot of good studies, whether you freeze an egg or you do IVF with a fresh egg, your chance of pregnancy is the same with that egg. So it's not like freezing an egg will lower your chance of pregnancy, which is why it's no longer experimental and it's considered standard of care for fertility preservation.
Got it.
So it's a great method for fertility preservation. We just, you know, once you have frozen eggs, it's just, the important point is that it's not a guarantee. It increases your chance.
Right. Okay, perfect.
Just as somebody who's gone through it and also who takes care of many, many patients who I have to talk about donor egg with, it's like, well, maybe let's think about egg freezing or fertility preservation. And a lot of people are doing it more and more. Thankfully, a lot of companies, a lot of insurance companies are paying for it, and not just in the setting of a cancer diagnosis, but just in the setting of social egg freezing. So
it's good to hear.
Yes.
Good.
So I'm happy about that. And then some takeaways. So I guess number one would be, you know, try to roll with the punches, because you don't know which setback is really something that may be a blessing in the future. And we just don't 100% know how things are going to play out. And I made that point, but I guess I would say, like I said, that's the top, the lesson I would learn in life, but also definitely in fertility. It's important to reach out for help. I really strongly believe that with a clear mind and with the appropriate mental health support, people are able to make better decisions.
Definitely.
And better decisions absolutely will inform or will affect your outcome. So, you know, in LA, we often talk about stress as the absolute evil, right? Nobody wants to be stressed because stress is going to affect you in so many ways. But I mean, I don't know. It's very hard to measure stress. It's hard to study stress. It's hard to really understand how stress affects our physiology. It probably does, but to what degree does it affect your egg quality? Who knows? We don't know all of that. But what I do know is that women and couples who are stressed and don't have the appropriate mental health support don't end up really making good decisions. They sometimes don't listen to their doctor. If their doctor is saying, okay, let's continue, you're going to do it, you're going to be fine, just keep going, or it's time to stop, right? It's hard to really let in the good advice if you're just not thinking clearly. And it's hard to think clearly if you don't have appropriate mental health support. So that's why I think it's important to reach out and get that support. And then a third thing, I mean, I guess I would just say it's sort of related to all of that. It's important to talk about, I think, your experience, but also to realize that there may be people you're speaking with who are going through this, who may want to be private about it. And I think my experience has kind of taught me to just be sensitive to things that I say, because, you know, you may be sitting with a group of people and talking about your experience, and most likely there's somebody in the group who's done IVF or is facing fertility issues who's not bringing it up. And so it's just, I think, there's this really cute article I saw somebody where it said, mind your own uterus, right? So it's, I think it's just about being careful about things that you say, because some things can be hurtful. And I think that Yesh Tikva, I think it's almost like their mission statement almost is about that, right? Like, you kind of be careful about what you say and be supportive, but just really be careful about what you say, because you don't know who's going through fertility treatment. You don't know who having fertility issues. Right. And it really is, it can be very private for people, and things that you say can affect them.
Right. I think that's a great way to end, to say that as much as you know, like, you're so, and I appreciate your honesty and your openness about your own story, and to not make the assumption that somebody else wants to be just as open and just as kind of revealing about their story. So kind of minding that awareness of being aware of whether somebody wants to share with you or does not want to share with you, that is their choice, especially in a situation where this feels like there is no privacy anymore, right? This whole process is one of losing privacy. Right. And so I really appreciate that concept of respecting where each person is. Absolutely. So I really appreciate the time that you allowed us to chat. I know it's like in between your patients. Thank you for spending the time with me. I'm sure we'll pick it up again at another time, but thank you. And everybody should know that Yesh Tikva is here to support you. We have multiple support groups for men, for women. We have, we recently started an art therapy group online, which is just amazing that we've been able to offer these kind of virtual resources and encourage you to reach out to us and Check in on our Fertility Friend Mentorship Program as well. And we hope that you are staying safe and healthy, and we look forward to hearing from you soon.